name's Dr. Farrukh Shah. I'm the Medical Director for Transfusion at NHS Blood and Transplant, and I'm also a haemoglobinopathy consultant looking after patients with sickle cell disease and thalassemia at the Whittington Hospital. And in fact, for many years before I joined the blood service, I was a thalassemia doctor, still identify as one. So I just want to say welcome to everyone who's joining the session. We're going to start off with some general housekeeping rules. The first one is obviously your microphones have been disabled for the duration of the webinar. If you do want to ask a question, please put your questions in the chat Q&A function, or during the Q&A, you can raise your hand and we will then try and answer the questions. It would be very good if the questions are actually written in the Q&A section, because then we make sure that we don't miss relevant questions. What's really important is that you can have translation captioning, and I will talk through that on the next slide. When we are in the chat function, please do be polite with colleagues and in your questions. Please don't post any other material unrelated to today's discussion in the topic. And if you can, keep the discussion and the comment on the topic as much as possible. GANSID does reserve the right to pause a session or seek removal of participants if those rules are not abided by. And I'd be very keen that we have a really interactive and positive discussion today on this particular topic around blood supply. So translation caption, at the bottom of your screen, you will see the buttons where there's shared screen and all of those kind of buttons. There is a button at the bottom of the screen which says caption. And when you click on that button, you can choose the language that you want the caption to be translated in. And we have started the recording, so you should be able to choose your language for translation. So this is an interactive session today, and and the recording of the session will be posted on the website. I'm going to be using a quiz using a VVox app, and so please do follow the link. I'm going to give everyone at least a minute to have a look at the VVox link and download it and open it up. So I hope everyone can scan the QR code and actually join the VVox app to participate in the session. I'm doing this for the first time on Zoom. I'm really hopeful it's going to work. It will be very sad if I don't get my word clouds for the session. So, and it's not an exam. It's actually a really fun set of questions that you'll be asked to take part in, and hopefully we'll learn lots about people's challenges within their services, within their regions, around ensuring a safe and secure blood supply for patients who actually need blood, particularly the haemoglobinopathy patients, where transfusion is absolutely life-saving for the majority of patients. So I'm going to give it another few seconds, and then I'm going to flip over to the next slide, and I'm going to open the poll for the next slide. So the next slide is please say hello in your language. So I'm just going to wait another few minutes so that people have time to get into VVox and actually try and join the poll. Right, okay, so hopefully that's given everyone enough time to join the poll. And I'm going to move on to, okay, we've got a Q&A, just bear with me in case, okay. If you can, it would be really good to put the hello into the VVox poll. Okay, so next slide is the result for the hello. Hopefully. I'm hoping it's going to show up in the word cloud. I don't know why that's not worked. Reopen. Oh, here we go. Stop poll. Here we go. So unfortunately, that didn't work very well. I'm hoping the next one will. So the next question is, which country are you living in? Okay, so I'm hoping that this will, if you can use the VVox link, please, to put in the answers for the poll. I think people are joining. I'm just going to go back to the VVox page so that people can join in on the VVox poll at the beginning. Okay, so bear with me for a few seconds, and I'm just going to slide back. Okay, so for people who are joining, this is the VVox QR code that you need to select. So please do log into, and it would be really good actually if people can in the chat just add that they've managed to join into that particular VVox link. Okay. Great. So if you can get into the QR, if you can get into the VVox, then we will open up the poll again. So what I would like everyone to do is to please say hello in your language. And so this poll is now running. So what you can do is look at the QR code and enter that, and then hopefully give a answer in the QR code about what your language is, and say hello in your language, okay?
Hello, Dr. Farrukh. I also posted a link to the VVox inside the chat as well. So if someone has trouble scanning the QR code, there is a link in the chat where you can click the link to take you to VVox as well.
Perfect. Thank you so much.
My pleasure.
So I'm going to give everyone 30 seconds to go in and enter what they say hello in your language into the poll, okay? So if you can try and do that, that would be great, because it would be very nice to look at where people have come from to join the session. Okay, so we're just going to pop into the next slide, results slide. I don't know why this is not showing up the language. So here's our word cloud with Canada, Nigeria, and India. So the next one is, in which role are you joining this meeting? So if everyone can enter in here, in which role they are joining the meeting, as a healthcare provider or as a nurse or a blood supply person or someone who works in blood banking as a patient. So those are the kind of roles that I'd be really interested in. Fantastic. So I am getting a good number of people putting in comments there onto the poll. So I'm going to stop the poll, and when we move on to the next slide, hopefully. So we've got patient advocate, attendee, administrator, healthcare provider, patient support in the roles in which people are joining this meeting, which is excellent, which gives us a good range of people with different concerns around the blood supply chain. So the next question is, what are your concerns around safe and secure blood supply? So what are your individual concerns in whichever capacity you are joining around the safety and the security of your blood supply? So please do enter in your concerns. I think it's really important in the current environment that we have, what the major concerns are. So this is lovely. I'm getting a really good breadth of concerns here, and I'll be addressing a number of those concerns. So let's move on to the next slide with the results in it. So I think the way that things have sort of flown up in my word cloud doesn't work very well. But what we have is sustainability, transparency and proper testing being the main concerns around blood supply. So the next question is, what is your blood group? Do you know what is your blood group? And you basically choose your blood group. Fabulous. Okay, so we've got blood group AB, we've got blood group O and blood group. Fabulous. Right. And the next slide. Right. Okay. So you'll be relieved to know that there are no questions now for at least another few minutes. And I'm going to really talk about hereditary blood disorders and why blood transfusion is so important for this population. There are many hereditary blood disorders, but the most common and the ones where there's the largest need for blood supply are the sickle cell disorders and the thalassemia syndromes. The rarer anemias, such as the congenital dyserythropoietic anemias, transfusion-dependent G6PD, transfusion-dependent pyruvate kinase deficiency, and many, many more rare inherited blood anemias also require blood transfusion, but the numbers of those patients are considerably smaller than sickle cell and thalassemia. So patients are either blood transfusion dependent, as in the thalassemia transfusion dependent syndromes, or the transfusion dependent rare inherited anemia syndromes. All patients may actually need blood transfusion to either reduce the risk or prevent or treat complications. And patients with sickle cell disease fall into that particular group of patients. So for example, in sickle cell disease, we may use blood transfusion to treat acute chest syndrome. We may use blood transfusion to prevent sickle cell stroke in children who've got high transcranial Doppler flow rates and things like that. And in the non-transfusion dependent patients, again, very similarly, transfusion may be really needed in those patients to treat severe anemia during intercurrent illness, support women during a pregnancy, or may be used to treat complications such as extramedullary hematopoiesis and other problems. And the same applies to the non-transfusion dependent rare inherited anemias. For example, if someone with G6PD has a severe hemolytic crisis, they may end up needing a blood transfusion as a life-saving intervention at that particular time. What is the challenge? Well, the challenge really is that the population of patients is growing. And the reason for that is that less patients with these conditions are dying from their disease because they've not received adequate treatment when they were younger, which is a very good thing because it basically reflects the improvement in the quality of care and the availability of care globally for these patients. However, as the number of patients grow, we end up with a significant demand on services, and that is where the challenge lies. So this is a patient with very severe extramedullary hematopoiesis. This is a thalassemia intermediate patient. And just to kind of help people who are not medical, this is the spinal column, and this is the swelling of the bone marrow around the spinal column. And this will cause pressure on nerves, pressure on blood vessels, and all sorts of problems, and actually ultimately result in damage to the bone structure itself. This patient's mass is so big that she actually also had a very large mass coming out in the thoracic spine, which was pressing on her airway and causing her an absolutely terrible cough. And she actually presented to me with a cough. Her spleen is massively enlarged, her liver is massively enlarged. And this is the consequence of not transfusing a patient who has a thalassemia syndrome, and they can develop severe complications which make their quality of life and life expectancy significantly hampered. So, what is the burden of disease? Well, I just spoke about the fact that we are doing better for our patients and patients are surviving. But the other issue is, of course, that the birth rate for patients with these disorders continues to remain the same or very similar, because many countries don't have prenatal diagnosis. Now that blood is more easily available, patients are getting transfused to treat acute illnesses when they're younger, and hence they're surviving. And this is looking at the global epidemiology of sickle cell disease. And what you can see is that in countries where sickle was not an endemic condition, you've got migration causing sickle cell to be present. So in the UK, in Canada, and then in Africa and India and the MENA regions, you can see that there is a significant body of patients with these disorders that needs support. And Brazil and South America, again, very similarly severely affected by large populations of sickle cell disease patients. This is a cartogram done by Fred Peel and his team, looking at the global burden of disease and what we're likely to be dealing with in 2050. And I think the critical figure here is that this is 10,000 to 100,000, and here it's 100,000 to 1 million. And you can see that there is a massive increase in the haemoglobinopathy population, particularly sickle cell disease, in the African region and India. And those are actually low middle income and low resource countries within those regions. And that is where the biggest problem is actually going to lie, around blood supply. So why is blood so important, and why is the blood supply so important? Well, I'm going to talk from a UK perspective, okay? In the last, this is data looking from 2016 to 2022. I'm just going to move this a little bit because you might not be able to see the bottom of this. But what you can see here is that there is a steadily increasing demand for blood group RO. Blood group RO is, for the vast majority of patients, used for sickle cell blood transfusions. And we know that we needed a 30,000 demand frequency in 2016, and we now have a demand frequency of 47,000 for RO units, specifically for sickle cell patients. But many of this is not reported, but total RO units requested went from 55,000 in 2016-17 to 86,000 units in 2022-23. That tells us that the amount of blood that we're requiring year on year is steadily increasing, and how are we actually going to meet that demand is the real challenge, because we are transfusing patients more often, more frequently, to improve their clinical outcomes with regards to their underlying disease. So just to focus on the WHO, and I do think that the WHO has got some really robust data. About 118 million blood donations are collected globally, and 40% of those are actually collected in high-income countries, which is home to 16% of the world's population, and actually a minority of the patients with haemoglobinopathies. In low-income countries, up to 54% of the blood that is given to patients is actually given to children under the age of 5, whereas in the high-income countries, the vast majority of blood is given to people over the age of 60, predominantly those patients with leukemias, cancers, etc., those sort of conditions. Now, access to blood from the WHO figures, if you look at blood donation rates, and it's really important to think about blood donors from a blood supply perspective, 31.5 donations per 100, per 10,000 happen in high-income countries. But just compare that to 5 donations per 1,000 in low-income countries. And if you think about low-income countries, where the sickle and where the thalassemia population is, where the rare anemia population is, the vast majority of them are in lower middle income or low income countries, and their donations per 1,000 is vastly lower than the donations per 1,000 in comparison in high income countries. So one of the things in the word cloud, a concern on the word cloud, was around transfusion-transmitted infections and about making sure that patients were not being exposed to infections because of life-saving blood transfusion. And this is a table from the WHO. And what this really does show is that in high-income countries, because of the availability of appropriate testing and centralized blood banking services, and economies of scale, the risk of transfusion-transmitted infections is incredibly low. In contrast, in lower middle-income countries, you can see that the risk is considerably higher. Even though it's low, it is considerably higher than the risk in high-income countries. And then I just want people to focus on the hepatitis B, because this really does tell the story. If you look in low-income countries, the risk of getting hepatitis B infection from a transfusion is 2.81% in comparison to 0.02% in a high-income country. So there is, without a shadow of a doubt, an increasing risk of transfusion-transmitted infections in lower-income countries. And the main reason for that is around the availability of appropriate testing, and also the fact that the majority of those donors for blood are going to be either paid donors or family-related exchange donors. There are other transfusion-transmitted infections that are also very important and can cause really serious morbidity and mortality in patients. We test for some of those. Individual countries will test for these infections based on what their prevalence is. So hepatitis E is transfusion-transmitted. We've recently had a case in the UK. West Nile virus, cytomegalovirus, HTLV1 and 2, human papilloma B virus, malaria, trypanosomosis cruzi. Now, malaria is a real issue in Africa, but also in India and in the MENA region. And trypanosomosis cruzi is a big problem, obviously, in South America, where there is a very large population of people with sickle cell disease. So we're going to go back to Vivox. So I'm going to give everyone a few minutes because we need to pop into this. So please do open the app. There is a code in case you've been locked out of the app. That's the ID code 175901594. And the question is, what do you think is the biggest challenge to reducing transfusion-transmitted infections? So if you can try and answer that poll, I'm going to give everyone a couple of minutes because you may need to log back into the Vivox if you've come out of it. Right, so cost of testing is a really big challenge, and the availability of testing. So we know that the tests are reliable, but it is actually the cost of testing. Many countries where blood banking is not centralized, the testing is actually done by small non-government organizations or privately funded blood banks. And the cost of testing can be prohibitive. If you want to do a PCR test versus an antibody test, there is a significant difference in the price of those tests. And then obviously the availability of testing in many parts of rural Africa, rural India, and other countries, availability of testing is just not there for many patients. Right. So do you have access to blood tested for the following things? So these are looking at the core tests that everyone should do. So hepatitis B, C, syphilis, and then more specific testing if that is also available regionally. So I'm just going to leave this open for a few minutes as well to see if people can enter more availability if there is less availability of specific testing in your region. Right. Okay. So it looks like most people have testing availability for the core basic testing. That is absolutely the mandatory part of testing, but NAT testing isn't available to a lot of people. So I'm just going to now move on to talk about shot and hemovigilance, because I do think that hemovigilance, if we're talking about transfusion safety and safe and secure blood for patients, then hemovigilance is actually really important. The UK's hemovigilance scheme has been around since 1996. It is the oldest hemovigilance regime in the world. It is voluntary reporting. However, despite the voluntary reporting, what you can see from this graph here is that there has been a steady increase, which is consistent over the years for reporting. The number of units of blood that are actually transfused in the UK are about 1.6 million. NHS Blood and Transplant, my organisation, provides about 1.3 million units per annum. But if we look at platelets and FFP and various other things, we actually provide about 2.2 million units of blood products on an annual basis. And all of those are actually shot reportable if there is a hemovigilance issue. So I just want everyone to take a moment to stop and think a bit about blood transfusion and blood transfusion safety. So we have come out of, but are still actually partially living in, a COVID-19 pandemic. And thankfully, there was no evidence around this being transmitted through blood. And that's a good thing, but that doesn't mean that the next pandemic that we are going to have to deal with is not going to be a blood transmissible pandemic. And we do need to think about what is the next threat and what would your service do to manage this? You know, if the next pandemic is bloodborne, how are we going to manage this? If it's not bloodborne, we've learned some really important lessons from the pandemic, from the COVID-19 pandemic, around getting in donors and supporting blood donation, and also learned some important lessons about blood utilization during an active pandemic state, because we know that blood utilization went down in hospitals during lockdowns. So other factors affecting safety. So one of the critical things that everyone said at the beginning on the word cloud was the concern around infection, but actually the biggest risk to patient safety is not infection. It's not transfusion transmitted infections. It's actually errors during the transfusion pathway that are the biggest risks. And this is data from SHOT from this year's report, which has just been released. And you can see that 83% of incorrect blood transfusion incidents were related to errors, most of which were preventable. And then not preventable errors were about 9%, and possibly preventable were 7.5%. So where did these errors occur? Well, as part of collection of blood data from the SHOT committee, we do look at a range of different types of errors. So there is ADU, which is avoidable, delayed, and under or over transfusion. And then there's handling and storage errors, which you can see here in the yellow. And then incorrect blood transfused, wrong component transfused is the purple, dark purple color. An incorrect blood transfused specification requirement not met, i.e., product was, needed to be irradiated, wasn't irradiated, etc. That is pink. What I think the message I really want to drive home is to look at the blue box. You can see that the avoidable, delayed, under and over transfusion boxes have actually gone up as a percentage and numbers reported across all areas, across theatre, adult critical care, and across general wards. And these are completely avoidable scenarios that we really should be paying attention to. And you can see that the biggest risk is when departments are under a lot of pressure, when they're having to work really hard to achieve certain targets. You can see a practical doubling in those preventable hazards. So hemovigilance is a whole pathway, and it is not just what happens in the ward with the patient, but it is literally the whole pathway. And then this starts from the donor collection, recruitment, and the screening pathway into what you're doing with the blood donors at the time of donation and managing those donors and any complications and problems that they may have. That is all the front end of hemovigilance. And then obviously the screening, which is either mandatory or discretionary testing. We do all of the mandatory testing, and we do quite a lot of the discretionary testing for other infections based on if patients have been to Brazil, blood donors have been to Brazil, or if they've been to Africa, we will then trigger malaria testing, etc. And then hemovigilance is also focused on processing, storaging of blood and blood units within the blood service, and then any problems with the transport of products to the centres. So cold chain parameters are a really important marker for hemovigilance. And then within the hospital setting is the decision to transfuse the patient, the collection of the blood sample, the cross-matching of the sample, and the administration of the blood component, the monitoring of the patient, and reporting of any hemovigilance things to the MHRA or to SHOT. So hemovigilance is everybody's business, and hemovigilance ensures the safety of your patients at the end without a shadow of a doubt. And we need to ensure that not just the front end of hemovigilance, but also the unseen end of hemovigilance, i.e. what is happening within blood banks and within the processing and handling part of the hemovigilance pathway, is also appropriately monitored and complied with. So I'm going to now talk about security of blood supply. And so it's a very difficult time at the moment. There are many threats to blood supply globally, I think, on multiple levels. So there are disasters, man-made disasters and natural disasters, floods, storms, all sorts of things which can impact on this. Man-made disasters, things like war and what's happening in places like Gaza, following those kind of hemovigilance, good practice with regards to blood donation is actually really difficult in those kinds of situations. And patients ultimately are the ones that suffer because of lack of availability of blood, safe blood. And then pandemics, which can either be blood-borne or blood-borne pandemics. And the bulk of this is actually beyond human control. We just have to deal with the situation as it arises and then do our best and actually be a bit agile in how we approach things. And sometimes it does mean that you will be doing things outside of what is set criteria. And then other threats to the blood supply are supply chain factors and demand factors. And these are things that we can actually try and control, in part at least. So we're going to go back to the poll. So the question is, what is the biggest threat to the security of your blood supply? I'm going to give everyone a minute or so to try and log back into VBox and contribute to this particular thing. This is again a word cloud, so you can enter in several things if you want to enter those in. Okay, so just in case you're missing the VBox link, it's been posted in the chat session again. I'm going to reopen the poll because I've only got one word in there, which is accessibility. So let's see, do we get anything else? Okay, so accessibility is is a threat to the supply chain, which is really important because it's accessibility of the donors, accessibility for recipients, and other people who are involved in the process. So let me just go back to here. So I'm going to talk about the UK's Amber Alert, and an Amber Alert is was put out this time last year in the UK. An Amber Alert is called when there is less than 2 days blood stock in any blood group. And at that point, when we called the Amber Alert, we were at serious risk from not just one, but a couple of blood groups. And if you look here, this is our red cell stock monitoring by day based on collections. And here you can see that on the 10th of October, we had 2.2 days stock of blood group O pos, 2 days of O neg, and then we went down. And then for O neg, we were fast approaching a red alert, which is a below 1 day of stock, if we hadn't actually made any interventions. So we called an Amber Alert. This is a really big, major event. We have to think about the fact that we supplied blood to the whole of England. And if you've only got 1 day stock within your blood service, moving blood to where it's needed can be really very difficult. And you would get into a situation where you would need to ration, and you'd be worried about what happens if there's a major hemorrhage, a major obstetric hemorrhage, etc. So we did call the blood alert, the Amber Alert, and this went out to every hospital in England, which basically asked hospitals to activate their emergency blood management group, to prioritise urgent transfusions, to minimise transfusions in patients who didn't need them, and to consider doing 1 unit transfusions, rechecking the haemoglobin, and then considering further transfusion if needed. So there was a whole range of recommendations that came out of the Amber Alert that needed to be activated. So how did we actually get into this situation? Well, the problem is that stock is where everything starts. So, and stock is what you hold in your building, and that is always a balance between supply and demand. And if your supply goes up or your demand goes up, you will end up in a short, if your supply goes down and your demand goes up, you'll end up in a shortage situation. And if your supply goes up and your demand goes down, you'll end up with a surplus. And that is a problem because you don't want to waste a short shelf life product like blood. And that is terrible because donors donate blood so that they can save lives. And if you end up with surplus, you end up wasting blood, and that is really very unfair for the blood donors who've donated that blood. So NHS Blood and Transplant provides, it is a supply chain organisation. It provides blood to hospitals in England, and NHS Blood and Transplant covers the donor collection services, including the actual donation, all of the processing and testing, and the holding of blood stock and the delivery of blood stock to hospitals. Hospitals themselves hold a stock of blood in their blood banks, but they replenish that core stock daily, and they use that to transfuse patients who may require blood transfusion. It is a really multi-stepped, multi-pronged process within centralised blood banking services. And this is equally applicable to most highly developed countries and most middle-income countries, but actually something to aspire to for low middle-income countries where there's not central blood banking, and for low-resource countries. So what we do within our organisation is that we mobilise donors by blood group, and we collect the blood, and we use specific types of packs based on male, female, and what we're going to do with those blood units. Some of those blood units will be used to manufacture platelets. Some of them will be used to do a whole range of other things. After we've collected the blood will then be moved to the manufacturing site. We have 3 in England. And the mini packs that come off of the blood bag will be sent off for testing. We have 2 testing sites and we have 3 bacterial screening sites. Everything is barcoded so that we know and we can follow the results of the testing and the processing of the unit from end to end. And then there are specific units where we'll want to do some more detailed matching, such as HLA matching. We'll want to be doing a more extended antibody antigen matching, particularly for sickle cell patients. And we'll be identifying RO blood group units. Once we've done all of our manufacturing and processing, everything goes to the stock holding unit, of which there are 15 sites in the UK. We have a service requirement with hospitals that a stock holding unit should not be more than 2 hours away from the hospital. And that is primarily to ensure that we can get units of blood to the hospital in a timely fashion. So there are lots of things to consider about blood supply. We very much view ourselves as a patient-centered organisation, and that is because we're providing a critical, essential, life-saving product to hospitals that patients need. And if we were unable to do that for any reason at all, there would be serious patient harm because of that issue, and hence the Amber Alert was called, but also that's why we have very clear processes about what we need to do, when we need to do it. So in the UK, the manufacturing, distribution, supply chain is really complex. We have to monitor what we're collecting based on demand and make sure that we're not collecting more than is the demand. Otherwise, we'll end up in a surplus and end up wasting units of blood. Supply and demand are not beautiful, clear, parallel lines, unfortunately. And so you end up in situations like this. This is when the Amber Alert was called. And what you can see is the red line is the collections that we needed to make to meet requirements. And the blue line is the actual collections. And we had summer bank holiday here, so we collected less, and then we had the Queen's death and we collected less, and then we called the Amber Alert, and you can see that there was a massive increase in collections, and we went into a very good stock position, but demand, at the same time as the collections went up, demand went down because we'd asked hospitals to activate their emergency blood management plans and to reduce the amount of blood that they were using. So you can see that sometimes things can swing very quickly from one side to the other side without adequate planning. Now, we have been talking about supply and demand, and RO, blood group RO, is our biggest demand and supply challenge for patients with sickle cell disease. And so we actively work at recruiting more donors from Black and African Caribbean backgrounds because we need the RO blood. And we have had a steady increase in the number of people registered. So 9,500 donors down to up to 14,000 donors. However, only a third of the people that register for blood donation actually get to donation. And if you're comparing like with like, we had 9,000 there and 3,000 actually donated. And we've got 14,000 there and 5,500 have actually donated. So this is a real challenge that we need to see why our registered donors are not actually able to donate. So we're back into the VBox. So I'm going to give everyone a few minutes to get into VBox. And the question is, what is your biggest supply chain challenge? So if you can tell me, what is the biggest supply chain challenge for you? Is it the donor end, i.e. you don't have enough donors to give the blood? Or is it something else in the supply chain process that is your biggest challenge? Right, excellent. Right, so I'm going to show the result. Hopefully that will come. Might need to go back and just do that. Okay, let's try it again. Okay, and let's show that. Hopefully that will, there you go. So excellent. My word cloud has actually worked. We're getting better at this. Right. So habits that need changing is a really important thing. Working from home is a big problem within our supply chain. And that's one of the reasons why we landed up in the Amber Alert, was that a lot of people were working from home. We had less footfall in the fixed donor sessions. Restrictions to supply and barriers to supplying are other things that people have said. Now, the next poll is, what is your biggest demand challenge? So you're thinking here about what's happening in hospitals and within services where blood is needed, okay? So if you can contribute to the word cloud there, that would be excellent. So just as a reminder, you're thinking with regards to demand about what is happening. Okay, so we've got one comment coming in. So let's put on to the next poll. The next, is that the result? Oh, it's preparing, okay. Right, so the demand of all of the 4 blood types is a really important challenge. It's ensuring that you can actually provide all of the different blood groups. And that's really important. We called an Amber Alert because our OPOS and ONEG blood groups were very low. And there was a concern that we wouldn't be able to supply the right blood group. And all types being available is, without a shadow of a doubt, a real concern. So I'm going to stop presenting for a bit, and we're going to go into the Q&A session. Let's, can everyone type in questions into the Q&A rather than into the chat? I will have a quick look at the chat. We have had people responding to questions that I've asked in the chat, and one of the challenges to supply and demand is less time for donors, and sometimes demand just being very, very high, or reduction in donations. Okay, so we've got 2 questions in the Q&A. One is how to motivate a new donor. I think that's a really important question. One of our biggest challenges with regards donors is the fact that, you know, they are doing it for altruistic reasons. So it's a voluntary, unpaid, non-remunerated donation. I think the critical thing is to reassure people that they will not suffer any significant consequences from donating blood. There are real cultural anxieties around donating blood. In some societies, there's concerns that if you donate blood, you'll become impotent. In other societies, there's concerns about weakness and the fact that you will not replace the blood that you have donated. And it takes away the strength of the person who's donating blood. So those are actually really very significant concerns that we do need to address for patients, not for patients, for blood donors. And reassurance, I think, is one of the most important things. One of the things that we do within the UK, because we need more blood from African and Caribbean donors, is that we have campaigns, ad campaigns, which go into newspapers, into radio, into TV, asking for people to donate, and having donors, blood donors, actually contributing to those campaigns, and patients who need blood contributing to those campaigns. So it motivates people when they see that someone actually needs their blood to stay alive. And it motivates people when they see that a donor has donated blood and they've been completely fine, had no problems. So all of those things are actually really very important in motivating people to donate. I'd be really interested to hear how other countries help support blood donation. So one of the people in the chat has actually said that less footfall into donation centres with more work from home, and have we seen innovative or new ways to encourage people to donate? We have mobile units within NHS Blood and Transplant, and many countries do mobile blood collection. Certainly in countries which are low resourced, many non-government organisations will go to schools, colleges, universities, and places like that and do blood banking drives. What we have done is that we book people in advance into mobile units. We post on our website where the mobile units are. People can book in to those sessions, and then we can donate. They can donate somewhere closer to home on a mobile unit. Our biggest challenge has been the donor centres being in city centres and less footfall. But the other thing that we are doing is that we are now setting up NHS blood and transplant donation centres in shopping centres. So we will fit out a venue at a shopping centre, a shop, and that will then become a blood donation centre. So we've done that at Stratford and in Westfield at Stratford, and that is actually pretty effective at getting blood donors in, because they'll be out shopping in the mall and then they can pop in and do a blood donation. Another question here: how do blood donor organisations collaborate and or share information and best practice with other European countries? And I think that's a really good question. So our blood service works very closely with the other UK blood services, and there is a UK forum for blood services, but we also work globally with the ABO blood group, which is the Allied Blood Organisation Alliance, and basically we share good practice. We have regular meetings. There will be meetings between people in supply, people in demand planning, people in the CEOs and the medical directors to discuss key issues around both blood security, safety, supply, and all of the aspects around that. We're working very hard at the moment at getting plasma and getting plasma fractionation set up from UK blood donors. And there has been a lot of discussion with European blood services, with global blood services, American, Canadian, Australian, to ensure that rules, regulations, evidence is all appropriately applied, appropriately shared, and appropriately used. So we've got a question here in the webinar chat, which is what international blood safety guidelines? So there are blood safety guidelines. There's obviously the UK JPAC website Red Book, which is the one that I am most familiar with, which goes from the donor all the way through to blood product specification and all of those kind of aspects. Most countries with good resources, i.e. high-income countries with centralised blood services, will have clear guidelines on those sort of aspects. But there's plenty of literature and published guidelines everywhere from a resource perspective to help support centres and countries where they're trying to develop. And also there's the WHO website, which has also got documentation on it around what blood services need to provide and what the product requirement, not in as much detail, but what the product requirement is for provision of a safe blood service. Right, I'm just opening up the Q&A bit again because I'm answering questions in the chat, but there hasn't been many in the Q&A. Does anyone have any more questions at all? Are there questions that people would like to ask? We've got plenty of time, by the way, and I'm going to end on some slides at the end. So I will do another slide share. But I do, I'm very happy to help answer any further questions that people may have. Okay, so... Right, question, considering limited resources and time, what can patient advocacy organisations do to help? In many countries, we're very fortunate in the UK, but in many countries, blood supply for haemoglobinopathy patients is actually only provided by patient advocacy organisations. That's the non-government organizations. For example, in Pakistan, there's an organization called Fatmeed Foundation. They do blood banking drives. They provide blood to thalassemia patients across the country. And this is actually the state of affairs, this very similar state of affairs in countries like India as well, Nepal and other countries, where the patient advocacy organizations are the only ones that are able to help in some form to meet the supply challenges and reduce the demand intensity that centers have to deal with. So, and in the Western world, we really do rely on organizations such as the Sickle Cell Society to help with the advocacy work around collecting blood from Black and African Caribbean donors, because we need to meet the RO demand for blood for those patients. In the UK, the biggest challenge is obviously the bulk of our blood, a large proportion of our blood is being used by people with sickle cell disease. Our donors are white. They're of a different blood group, antigen profile in comparison to the recipients, which are by and large the sickle cell patients who have got other blood groups because of their ancestry. And we then end up with hemolytic transfusion reactions and other complications because of this discrepancy between the blood group antigens. So we use our societies to help mobilize and activate and encourage people from those communities to donate blood. But in other countries, I think the patient advocacy organizations are absolutely front and center in helping to ensure that there is an adequate blood supply, because they mobilize donors so that they can collect blood for the patients that they're actually treating quite often. Hello, Riyadh. Nice to have a question from you. So your question is, what is the precautionary measure deferral policy for blood donors who have lived in high malarial regions? So it's very easy for me to say that in the UK we do this. But if you're living in a malaria endemic region and you need blood supply, you cannot say you can't have traveled for 2 years to a malarial endemic region. So I think the question is really either very specific to Western services, or we have to develop an alternative strategy for endemic regions. In the UK, we as part of our donor questionnaire, we will ask people their travel history. If they've traveled to an endemic region, they will have specialist testing for malaria antigen. And if the malaria antigen is positive, we won't be able to use their unit. It will then be utilized for something else, such as plasma, for example, or it will be used for non-clinical issue. And we'll ask the donor to not donate until a period of time, and then retest to ensure that the antigen is no longer positive. The issue in other countries, particularly in the malarial endemic regions, needs to be managed in a different way, because, you know, the bulk of your population won't be suitable donors if they've had exposure to malaria. So the testing strategy has to be different, and the donor selection criteria have to be different based on the region in which you know, these kind of things are happening. Does that answer your question, Riyadh? I love this question. Thank you for asking it. Is there still a hold on donors with variant CJD? So basically, in simple terms, UK blood donors and plasma in particular is now okay to use for plasma fractionation. The risk of variant CJD from blood donors in the UK is very, very minimal. Many countries are now lifting their blanket ban for UK donors. And so UK donors are now able to donate blood. Now, this is a slow process. As far as I'm aware, the US hasn't started it yet, but are in the process of lifting their ban. Australia is also almost at the point of starting, if not has started, collecting blood from UK donors. So the situation is that the risk of variant CJD, and there's a number of papers that have been published looking at UK data, UK plasma safety, highlighting the fact that the risk of variant CJD transmission from UK blood donation is basically the same as the risk in Europe or the risk in the US or the risk in Australia or Canada. So the risk is not considered to be higher than any of the other high-resourced countries. But yes, this has been a real challenge. Variant CJD has been a real challenge for the UK services, and actually from a plasma fractionation, plasma collection point of view. And there has been a massive sigh of relief that this is now no longer going to be viewed as a major challenge going forwards. Right. Any other questions? Okay. Is there a movement in Europe to move towards platelet blood donation? No. Absolutely. I think this is a really important point, that there is plenty of data to show that if you have voluntary, non-remunerated blood donation, you have people who are doing it for an altruistic reason, those blood donations are, from a viral infection transmission risk point of view, very, very clean donations, and you're much less likely to have other health conditions, because people will donate because they're healthy and they're well, and they're doing it for a good cause and a good reason. Paid donors, the motivation to donate is different. It is money, and people will donate whether they're well or not well, because the driver is money. And therefore, paid donation, and people will then take iron supplementation to bring up their hemoglobin and donate more frequently. And paid donation, therefore, is a bad donation strategy to use in any patient, in any population, in any donor population, because the drivers become different. From a red blood cell perspective, the drivers become different, and there are risks associated with that. I don't think there will ever be a drive to do paid donation for red cells. Now, the situation around plasma may be different. But, certainly in the UK, we are heavily dependent on and only use non-remunerated voluntary donors who are doing it for a good cause, predominantly to save the lives of patients who are dependent on blood and blood products. Right? Any more questions? Right. I'm going to go back to my slide deck, and we are going to do the last set of slides. Back to Vivox, everyone. So my final question is, how are you feeling about your blood supply within your region, and what the challenges there may be for your blood service within your region? And you've got to bear with me, because I'm just about to open the poll. And so the poll is now open. So if you can link into Vivox, and the ID is at the top there on the screen. And if you can, it would be very good to see how you're feeling about your blood supply. You might have a headache, but the question is about how are you feeling about your blood supply. So I'm going to ask people to just put it into the chat. How are you feeling about your blood supply? Because it doesn't seem to be working on my slideshow. Have I just created a load of anxiety for everybody? That's the important question. Okay, so we've got one person who's worried following my presentation about getting all the blood types, which I think is really very important. It is a concern, particularly, if you're in a country where there's lots of patients who may be at risk of needing blood, and you've got a load of challenges with the blood supply, then ensuring safe supply of all blood groups is actually a real problem. And I certainly know that thalassemia patients are quite often under-transfused because they're blood group O negative, and O negative is just not available quite often, and they'll end up getting 1 unit instead of 2, etc. So another comment, but not worried due to the presentation, but just reminded about how precarious the blood supply actually is. Okay, great, thank you. So I want to thank everybody for joining this session. And I'm sorry that the VBox didn't quite work as well as I had hoped it would. It's probably my incompetence at using this, because it was the first time I was using this. But I do want to say thank you very much for attending the session. I hope you found the presentation useful as well as the Q&A useful. And please do join us for the plenary session, which is starting at 8:30 Eastern time, which is basically in 15 minutes time. And expanding the global data collection and clinical research session and addressing gaps through collaboration initiatives. Okay, so thank you all very much for joining this session. And please do answer the closing poll, which should have just flashed up on your screen. All right, thank you.